Welcome to another episode of the brand called You, a podcast and podcast show that brings you leadership lessons, knowledge, experience, and wisdom from thousands of successful individuals from around the world. I'm your host, Ashutosh Garg, and today I'm delighted to welcome a very senior and respected medical doctor from Kashipur, India, Dr. Kushal Agrawal. Dr. Agrawal, welcome to the show.
Thank you so much for having me, sir.
Dr. Agrawal is a neonatologist and the head of department of the Department of Neonatology and Pediatrics of the KVR Hospital, Kashipur. So, Dr. Agrawal, my first question to you, growing up in Kashipur, what role did your father play in shaping your dream to become a doctor?
All right. I think you started with the basic core of the way I became a doctor. So actually, what happens is that being a doctor is less to do with just reading books and passing exams. It's more than that. You have to be certain that you're ready to give up on quite a few of the luxuries
Yeah,
of life.
yeah.
And that is a basic problem that many youngsters who become doctor, they become disillusioned later on.
Mm,
They have this glamorous view of life that okay, fine, this is going to happen, and we're going to have a lot of respect, and people are like a small incident. Whenever you go to a particular trade or a shop or somewhere, you get a particular service. All right, you say, all right, the person delivering you the service says thank you to you. In
mm,
medical service, it is the other way around. When the person comes to you, he comes with folded hands, and when they're leaving, they're satisfied. Even if they're dissatisfied,
mm,
they generally say thank you, and they say that we are indebted for you. We are indebted to you.
mm,
You've cured us.
mm.
But behind the scene is a very different story.
Right.
I saw my father do that. I saw his dedication every single day. He
Mm,
wasn't just a doctor. Okay, he wasn't. People didn't come to him just for getting their prescriptions filled. It was he treated it as a service. It was like a
mm,
mission.
mm,
They came for comfort. They came for trust. As a child, I saw him, give up his personal comfort, personal time. I mean, for example, if I've been to the hostel, the Doon school, Dehradun, I was there for 5 years. I think he came, I think, twice or thrice to meet me. That was the upper limit. So there were a lot of there are a lot of things that he gave up on. So the dream of becoming a doctor was not born out of your textbooks or reading or anything of that sort, because there was a sense of responsibility that he instilled.
mhm.
He actually showed that as a human being, we can do something more. He was the first pediatrician in Kashipur.
Wow.
This was the first NICU in the whole of Kumaon region. That's how
Mm,
Uttaranchal,
yeah.
Uttaranchal divided into Kumaon
Mm,
and
mm,
Garhwal.
mm, mm.
So I saw him push himself to achieve something bigger than
Correct.
what was actually possible. So
Yeah,
that kind of sense that was what was instilled, that we can do something more than what is expected of us.
very
We are
true.
human beings. We can do something. We can achieve. We can
Absolutely.
try for something bigger. So
Absolutely.
that was something which was there.
Amazing. But I was reading about you. You also were selected in probably one of the most prestigious institutes of India, All India Institute of Medical Sciences, and you gave up a seat in ophthalmology to pursue pediatrics.
Yes, sir.
What went through your mind at that critical decision point?
So on paper, yes, it was a very tough decision. Like AIIMS Ophthalmology, it's a very prestigious
Hmm.
seat. The institute is worldwide known. It's a secured and it's a respected path. But I knew that, okay, fine, looking back, and if I think of 10 years down the line, if I look back on my decision, on my journey,
Hmm.
what will be more fruitful or what will provide me with more comfort, whether it be the surgeries which I've done, or is it the impact which I would have made in the family's life.
Hmm.
I'm not
Yeah.
taking it away from any field, but
Hmm.
the juncture at which a neonatologist comes into the life of the family
Hmm.
changes the whole trajectory
Right.
of the entire, the extended family.
Hmm.
It's about the impact, because with pediatrics, it's every single day that I have a chance to prevent sufferings early, to make a family whole.
Mm.
Because where neonatologist comes in is at that very crucial and critical juncture, that
Mm.
a mother has had a baby in a womb for 9 months. They've built a life story around themselves.
Correct.
They are, envisioning a secured life, and they're building up thinking, we'll buy this, we'll
Correct.
do it. Imagine that. The
Yeah.
grandparents are building up a lot of things. Okay, we'll get to relive the childhood which we missed maybe with our kids. And then suddenly, within a minute, the baby is born, and then there's a whole avalanche of misinformation and bad information and bad things which fall upon them. And the neonatologist comes and just takes the baby away to the NICU. That is a very crucial juncture.
Correct.
So that is somehow which I thought, and I realized, no, that is going to provide me with more
Mm.
comfort if I talk about.
Very, very interesting. Great response. Thank you. And one more question before I come to neonatology. You also have become a healthcare entrepreneur while being a medical doctor yourself. How did you manage this transition of being a doctor and becoming a healthcare entrepreneur while setting KVR Hospital?
So the transition was not smooth.
I
In
can
fact,
imagine.
one of the toughest phases of my life. See, as doctors, we are trained to think clinically. We are trained to
Correct.
think one patient at a time.
Mm.
But when you're building a hospital, you have to think of it in systems. You have to think of it in processes. There's a whole lot more that goes into it. So in the beginning,
Mm.
I thought that I'd be actually wearing both the hats. I'll be wearing two different hats. But as time went by, I realized that no, they're not uh, exclusive of each other. They are inherently mutually inclusive. So what I'm
Mm.
trying to make the statement is that I gradually realized they're not separate. What happens is, when your clinical training kicks in, makes you treat one patient.
Mm.
They tell us, okay, fine, this is one patient, got to give them empathy, you've got to give them accessibility, you've got to give them affordability, you've got to give them advanced care, and the 4 A's, which are prerequisite of any doctors. It's affordability, accessibility, affability, and advanced care, which is there. They're the 4 A's of any.
Mm. Mm.
As an entrepreneur, it just gave me the tools, it kind of trained me to deliver that at scale.
Mm.
That is the only difference. So it was tough. I surrounded myself with mentors. I surrounded myself with people who were actually good at making processes. So I developed my skills on the go. I kept reminding myself as to why, because there are a lot of frustration which comes in, that, at times there is a certain bit of deficit which goes into your clinical practice.
Mm.
At times it becomes frustrating, but keep reminding yourself of the bigger why, that you have to bring that. I have been given the responsibility to bring the most advanced or the metro level care,
Mm.
NICU level care, or the multi-specialty services to Kashipur. And Kashipur is a rural area
Correct.
in Uttarakhand.
Correct.
So the families don't have to travel hundreds of kilometers in emergencies.
Yeah.
The basic crux, which my father also, I mean, which we work, is that money should not be the barrier
Right.
for your life.
Very
You should stay
interesting.
for them to
Very
have good.
interesting. Very, very great response. Thank you. So tell me, Doctor, how would you describe the current state of neonatal and pediatric healthcare in India, especially in smaller towns? And that's an area of your specialization where you and your father have given back so much.
So in metros, the curve is rising really fast. So
Hmm.
their NICUs are sophisticated, their protocols are very tight, they have access to good infrastructure, to
Hmm.
stable and reliable infrastructure. In tier two, tier three cities, and frankly, if I talk about Kashipur, I don't even think we fall into the tier system.
Right.
So the intent is strong, but the infrastructure, trained manpower, and the referral systems is uneven.
Hmm.
So the good news is that the evidence-based interventions, the low-cost intervention, they work brilliantly outside the big cities where the
Hmm.
systems are set up. But what we need is consistency. We need reliable power. We need oxygen. We need trained manpower, standardized protocols, and a functioning transport network. So
Hmm.
in lack is not actually the solutions. It's about the standardization and the last mile execution, which is lacking in the tier three or rural
Very
setup.
interesting. Very interesting. And in your experience, what are some of the more common preventable causes of newborn deaths in rural and semi-urban India, other than, of course, infrastructure?
Also, the preventable causes which are there with premature, if you talk about late presentation, it's about the referrals which are there at a later stage.
Hmm.
And you got your fragile supply chains, the basic life support medicines.
Hmm.
Those supply chains are a little tough to manage in
Hmm.
rural areas, and the staffing. So what happens is the babies reach us late because the referral systems or the triggers of the referral triggers, they are inconsistent, and the transport is unsafe. The
Hmm.
supply chains, for example, for surfactants. Surfactants is a medicine which we give in the lungs for premature babies to help them mature. And now you add to that your power instability, your infection control challenges, your trained neonatal nurses and respiratory therapists. So those are the challenges which are a problem in the rural areas.
Hmm. Amazing. And what are the biggest barriers to equitable neonatal care in India today?
Okay, so the biggest barriers is not, frankly, the geography. It's a lot more. So you'll be surprised at the fragmented reference pathways.
Hmm.
See, there are a lot of pockets which are good, doing good work, but because of the weak transport, there is, frankly, no NICU grade ambulances which are
Hmm.
available. You got your power and oxygen reliability, you got your staff, you got your affordability fears, you got your varied protocol adherences. So
Hmm.
what we actually need is hub and spoke model,
Hmm.
24/7 unitology, tele backup. You got your payment protection for the at least for the first 48 to 72 hours.
Hmm.
Outcome based accreditation to centers.
Hmm.
For example, at times the accreditations are dependent on the bed numbers. Okay, yeah, there's such a so many bedded. Shouldn't be that. It should be based on the
Correct.
outcomes. We've
Correct.
got a lot of accreditation panels in place. You've got QCI, you've got NABH, you've got DNB, you've got NNF for
Hmm.
Neonatology, for National
Hmm.
Neonatology
Hmm.
Forum. So, there must be what only one or two, and in Kashipur I'm the only one, in Kumaon I'm also pretty sure I'm the only one which
Hmm.
have all the accreditation. So these
Hmm.
accreditation bodies, if they are there, they will really help in the equitable neonatal care.
Hmm. Amazing. And tell me, you must be meeting so many young parents and grandparents. What are some of the misconceptions you often encounter among parents and grandparents regarding newborn health?
Okay, so misconception. This is such a minefield, very
I
common.
know, I know.
So you got your pre-lacteal feeds. Like honey or the ghee, they are termed as immunity boosters.
Hmm.
People still feel that गाय का दूध या भैंस का दूध, the formula is actually better than the mother's milk.
Right.
They feel that early bathing is a must. You have to bathe the child as soon as possible. They think that gripe water is safe. They
Hmm.
consider antibiotics as some kind of vitamins. They
Hmm.
feel that chabyar is healthy. कि
Wow.
अरे अरे देखो गोलू तो है.
Hmm.
Trying to explain it to them कि गुब्बारा भी गोलू होता है. Doesn't mean
Hmm.
that it has any strength.
Correct, correct, correct.
So the reframing has to happen that colostrum is the first milk
Hmm.
which is given by the mother. The first
Hmm.
milk, it's actually
Hmm.
yellowish in color.
Hmm.
Colostrum is actually the baby's first vaccine.
Hmm.
Warmth, hygiene, your exclusive breastfeeding, they beat most of your so-called remedies.
Hmm. Very interesting. And you were just telling me about the lack of infrastructure in tier two and tier three cities. What do you think governments, state governments, civil society can do to support the incredible work hospitals like you are doing to support newborn health? And we always talk about India's demographic dividend and how young our population is.
Okay, so see what we have are pockets of excellence, but many islands without any bridges.
Hmm.
For example, so in neonatal emergencies, when you talk about it, basically neonatology is a department of emergencies.
Hmm.
So emergencies isn't just having a ventilator ready. It is about having a system which is ready at 2 a.m.
Mm.
So you need to have, for emergency readiness, you need four things. You need reliable power, oxygen. You need 24/7 your neonatal nurses, which
Mm.
should be present. It should be the basic resuscitation gear
Mm.
and a neonatology helpline for escalation and the transport.
Mm.
A simple birth attendant, a trained birth attendant at delivery point
Mm. Mm.
will go a long way in reducing the neonatal mortality.
Mm. Very interesting. I was reading up a little bit and I found that even though we produce a lot of doctors in India, there are very few neonatologists.
Yes, sir.
Why is this the case and what needs to change in our training?
So the problem that we have few neonatologists is that we have few fellowship seats outside the metros.
Mm.
You need to mandate rotations in the district level NICUs.
Mm.
We need to have simulation based training
Mm.
because the initial curve of learning in the NICU is steep because you have ventilator,
Mm.
you have your central lines,
Mm.
you got your resuscitations. So those training modules should be there,
Mm.
and private centers are more than happy to collaborate with
Correct.
districtable NICUs to pass on the training.
Mm.
So what it is quality improvement projects,
Mm.
which has to be ingrained in the residents or the fellows
Mm.
right during their training. So we need to train. I mean, might seem a little weird, but we need to train where the babies are,
Mm.
not where the journals are.
Right.
We try to we always say, "Okay, okay, where is the center which has the maximum research?
Mm. Mm.
Well, let us focus on where the babies are."
Correct. 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 Great response. But tell me, do you think there are challenges young pediatricians face when they are wanting to choose neonatology as a super specialty?
Sir, a lot. See, there's a
Mm-hmm.
very perceived burnout rate. You have to have a very night heavy rosters which are there. So you have a very steep learning curve, like I mentioned. See, so the
Mm.
fix is not very tough. You need to
Mm.
have a team-based schedule. You need to have simulation labs which can build confidence in the students. You need to have mentorship networks. You need to have institutional protection with protocol-driven care.
Mm.
We need to develop a documentation culture because
Right.
we are in a litigious society. So when the teams and the training, they're strong, neonatology will become deeply rewarding. It will not be just a
Mm.
burden.
Very interesting. Very interesting. Next question for you, Dr. Agrawal, is what recent innovations in neonatal medicine are most relevant to India's healthcare setting?
So, I mean, you'll be amazed to hear, sir, that it's not about the way we are raising the bar or we are going up the pyramid in research. It's more about trickling down of basic standardized protocols to the
Mm.
grassroots levels.
Mm.
Because neonatal care is a pyramid-based
Mm.
system where the majority of the underserved population is at the bottom.
Mm.
And they frankly do not need very, very advanced care.
Right.
They need basic protocolized care. For example, in India, you talk about bubble CPAP,
Mm.
a good working bubble CPAP right at the time of delivery, if provided, it'll go a long way in
Mm.
reducing mortality. You got things like KMC wards. You got your things like point of care ultrasound.
Mm.
You got your things like cord care, hygiene, the basic. It's not about the very high-end technology. It's about the technology which has to be paired with disciplined protocol.
Right.
That is going to go the long way.
Mm. Very interesting. What are your thoughts on the use of AI and digital monitoring in the NICUs? And are you using it? And do you see this expanding or supporting your work in a big way?
So definitely. So it's going to be supporting us. You have to, so the point is that AI is going to help us in detecting early signs of apnea. Apnea is stopping of breath,
Mm.
of breathing of the baby.
Mm.
So it's going to help us in detecting apnea or infection.
Hmm.
It is going to reduce the alarm fatigue. It's going to guide the staffing.
Hmm.
But it is going to be a co-pilot.
Hmm.
The pilot will still be the clinician and the nursing team. So it's not
Hmm.
only the clinician. And ICU is a teamwork. So it has to be a part of the team. So when we are
Hmm.
working on the floor, I always tell my team that all of us are working shoulder to shoulder. It is a big boat which we need to carry.
Yeah.
It cannot work that two shoulders are high up and the rest of the shoulders are down. We cannot carry a boat like that. All the shoulders have to be at the same level. So
Hmm.
when we are standing on the NICU floor,
Yeah.
all of us are equal. It's a
Correct.
team, and all of us are equally responsible in making sure that the baby who's fragile, if you look at it like a small your candle, and we have to make sure that this candle keeps burning across the length of the tunnel. And it's
Hmm.
all of us who have to work and make sure that this candle keeps burning at the end of the tunnel.
Very well
So
said.
it's a team, and AI will complement us.
Absolutely. I have time for two more questions for you. Um, what makes treating premature and underweight babies in India particularly challenging as compared to developed countries?
Okay. So basically, the main concern in premature babies in developed nations and our country is basically the late presentations. It is the staffing
Hmm.
and our supply chains.
Hmm.
The baby reaches late. There are the referral triggers, like I mentioned earlier, they are inconsistent. The transport is unsafe. The supply chains are patchy at times.
Hmm.
The trained neonatal nurses, the respiratory therapists, they are the biggest challenge. So it isn't prematurity, frankly, which is making us lag behind the advanced countries. It's about the delay, is the
Hmm.
distance, and the disorganization, which
Hmm. Okay. And my last question for you. Are there any indigenous low-cost solutions that you have seen making a big impact in neonatal care?
So we got low cost solution. There plenty. Like there's a bamboo style hypothermia band which is there, which parents can use. There's the bubble CPAP circuits which are there. The
Hmm.
standardized infection prevention kits, like you got your bundle protection. So these are the low cost solutions. Like KMC, you got your kangaroo mother care, early breastfeeding initiation. These are the low cost solutions which are making the big impact. Simple
Hmm.
hand washing goes a long way.
Hmm. Very interesting. But on that note, Dr. Agrawal, I just want to say this has been such a fascinating conversation for me. I mean, I have spoken to some doctors, but not too many on my podcast. And talking to you has given me a very, very new perspective on neonatology and the amazing work doctors like you and you are doing for protecting the babies of our country. Thank you for all the great work you're doing, and thank you for speaking to me. Good luck.
Thank you, sir.
Thank you for listening to the Brand Called You videocast and podcast, a platform that brings you knowledge, experience, and wisdom of hundreds of successful individuals from around the world. Do visit our website www.tbcy.in to watch and listen to the stories of many more individuals. You can also follow us on YouTube, Facebook, Instagram, and Twitter. Just search for the Brand Called You.